Hi everyone, I am here with Dr. Aseem Sharma at Bandstand and we'll be talking about the hairs. Hair is identity, hair is culture. And we have loads of problems in currently related with the hair loss. Whether it is a bigger city or it is a small village, some or the other hair disorder is affecting individuals. Today we'll be seeing that what treatment works, what treatment doesn't. We have the hair expert over here और हम लोग सारी therapies, multiple therapies की बात करेंगे and we'll see that what and how Dr. Sharma, prescribes and he deals with all his patients and give them a head full of hairs. Dr. Sharma.
Rahul, first of all, thank you so much for having me here and very, very thankful to DocShots and Connect to Clinic for this wonderful venture. I think the aim here is to bring doctors and patients close together, to be on one single page, so that when we are prescribing something, we know how to use it to the best of our abilities and the best of the molecule's potential. So I think, Rahul, you're absolutely right when you talk about hair, hope versus hype, because there's so many things now that are available. So many procedures happen within meters of where we are standing right now, this beautiful sea view. But how many of these are scientifically proven? How many of these things work in the long run? I think that is something that we'll cover in today's session. हमारा aim यहाँ पे बहुत simple है. We want to integrate patients and young dermatologists so that we are all on the same page and we all of us want the same thing. Rahul will tell you from personal experience, all of us want hair. We are just very confused because there are so many treatments now. Which treatments work, which treatments don't work, क्या hope है, क्या hype है. That is exactly what we are going to cover today. And Rahul, I agree with you. You mentioned that a lot of people now suffer from hair loss. In fact, when you look at data, scientific data, you will find the incidence is about 50%. But dermatology में या research में there is a term called point variance. जहाँ पे point variance means that 60% people will suffer from alopecia or hair loss or some form of hair fall at one point of time in their lives, which is a big number. आप किसी भी disease को देखें, if you look at epidemiology, this is a big number. 60% people suffering from a single disease, I think that's quite a high disease burden, and that is probably the reason we are doing a series like this.
So you had mentioned a very right point, hope versus the hair. As a patient, how much would be the expectation from your treatment?
Okay.
There is a tremendous psychological and social stress.
Absolutely.
So what is the expectation?
So that's an interesting question. Now what happens when it comes to hair is, the treatment has to be lifelong. Most treatments that we have right now, the commitment is very high. We were discussing, as a prelude to this session, how younger patients are getting hair fall. In fact, I think I saw an 8-year-old boy with patent hair loss. किसी को 8 years में start हुआ है, तो obviously by the time he's 20, he will lose almost everything. So we have to be very, very aggressive with these patients. At the same time, costs are higher and higher. We are obviously enjoying the sea right now, but living in a place like this is very expensive. It comes at a cost. How will you, balance the cost of treatment vis-a-vis living in a place like Mumbai or any other metropolitan city? I think these are a few things which we have to take with our stride. But yes, once a patient is started on Minoxidil, it is for life. There is no end to it. If the patient stops Minoxidil, तो you'll be buying time. थोड़े years आपको improvement मिला, जब आपने बंद किया उसके बाद it will start again. So unfortunately, that is the rule of the game. But there is definitely hope. And the earlier you start treatment, the more the hope is. Obviously, in some patients where the grade of balding is very advanced, वहाँ पे you might not be able to give treatment with medicines. You might have to throw in PRP, growth factor concentrate, or you might have to, counsel patients for a transplant. But I think those are situations which we tackle case-wise.
So what should be the ideal approach? There are aesthetic clinics which are open. There are dermatologists, there are cosmetologists, there are multiple, hair therapies.
Correct.
When a hair loss problem has started in an individual, and when you say it is a young guy, right, fighting hair loss in a smaller town, in a bigger city, what should he do? How should he look at it? What should he do? Exactly.
So, if a patient has started or if a younger person has started with hair loss, like I said, the results are actually better because you can start treatment early, you can arrest hair loss at a certain stage and then you can move forward. In hair, there is a very simple technique, thinning versus balding. So, if you have more balding than thinning, you don't have crop left in your hair. If you're giving fertilizer in the form of medical therapy, you are not going to get anywhere. So people who are more bald than thin, you automatically have to start with procedural treatments, maybe go up to a transplant, maybe not, depending on whether you want it or not or whether you need it or not. But that is the way you work backwards. Whereas when it just starts, patients always have thinning. That is the right time to hit people with the right treatment. And See, nowadays in a place like Mumbai, a lot of people are minoxidil phobic. They don't want minoxidil. Okay, doctor sahab, minoxidil to main chahiye hi nahi, steroid hai. So, earlier obviously, you know, being a government college guy, I would shun away patients. I would tell them, lena hai to lo, otherwise, you know, you have to take it. But now there are options. There are many peptides now which are, I won't say as good as minoxidil, nothing is as good as that, but it's a second best. So if patients do not want a lifelong commitment, if they feel that, you know, peptides will work, supplements will work, that is again something which can be done.
How do you, you know, when you say that minoxidil is something which is the gold standard, शादी कैसे कराते हो, sir? I will not take minoxidil more than 6 months. How the patient can develop a lifetime relationship with minoxidil? 6 months, 1 year, इससे ज़्यादा नहीं हो पाता, sir. It's not possible.
Correct. So I tell patients, आपका minoxidil का cost is the lowest amongst everything else. आप जैसे रात में dinner खाते हैं, you will apply minoxidil right after dinner. So it becomes a habit. आपने dessert खाया, dessert के साथ आपने minoxidil लगा लिया. Make it a habit. If you have done it for 21 days, you will be able to do it for life. And minoxidil के results इतने promising हैं शुरू में. Like I said, the correct thing is when you started. वो टाइम पे हिट करना बहुत जरूरी है. आपने 10 साल के बॉल्डनेस के बाद शुरू किया तो कुछ नहीं होने वाला है. बट व्हेन यू स्टार्ट अर्लियर, व्हेन पेशेंट्स गेट रिजल्ट्स, आप ये सोचिए, राहुल, जस्ट इमेजिन दैट यू आर गिविंग वन टॉपिकल मिनॉक्सिडिल सॉल्यूशन एंड दैट इज इट. No shampoos, no shampoos, nothing else to be used. I think that is where minoxidil has a big role to play.
So you immediately start with minoxidil. What are those choices of combinations when you look at minoxidil, as a monotherapy, as a combination therapy?
So interestingly now, with people who are coming in with hair loss, now there are two things now. One is hair loss, जो baldness या thinning के लिए patients are coming to us any which ways. The other thing is patients who are coming with hair fall, active hair fall. Patients बोल रहे हैं my hair are falling, झड़ रहे हैं बाल. In that situation, minoxidil causes immediate telogen release. यानी जो आपके hair dead हो चुके हैं, the cycle that is finished, those hair fall off, only then new hair will start growing. So उस समय अगर आपने minoxidil शुरू किया, patient compliance will be very poor. So उस समय in that panic stage, you use something like a peptide, you use something which is non-minoxidil, get the patient back, get the hair shedding down, and then you hit with minoxidil. That is how I take it.
So which are the combinations? With azelaic acid retinoin, with topical finasteride, with procapil, which are your choices of combination, and how do you look at the patient? How do you prescribe these combinations? Which are your favorite ones?
Okay, so I have no favorites as such. I prescribe almost everything that is available in our kitty now because you have to.
Yeah.
But if I have a younger patient with advanced grade of baldness, I want to hit the patient with everything. So I'll give them a combination of minoxidil with finasteride with procapil. That's a triple combination. We also now have pentaple combinations, जहाँ पे you have procapil, redensil, capexil, finasteride, and minoxidil. There are a couple of brands like that. See, I only feel all of these have stood the test of time in terms of inferiority. They are not inferior to anything else, but they are not superior. What I see in my practice a lot of times is patients are only on peptides, nothing else, and when they should have been started on minoxidil, they are not started at the right time. So that's something which I feel if I would have treated them maybe 5 years earlier, we would have had a very different picture clinically. But to come back to combinations, I am particularly fond of the liposomal combinations that are now in the market, the aqueous-based formulations. A lot of old timers used to face a lot of issues with minoxidil in terms of dandruff, hypersensitivity, itching. They did not like the cosmetic tolerability of it. Lipid-based formulations have now come into the market where penetration is very good and superficial side effects are less. So these are a few things I use when it comes to formulation of minoxidil. Combinations mein, like I said, finasteride is something I use. Azelaic and tretinoin has a role to play because it upregulates the sulfotransferase. So minoxidil ka activation is much more in the scalp. But again, I feel it's an overkill for androgenetic alopecia. Yes, for younger patients with single patches of alopecia areata, that is probably where I would use that combination of azelaic and tretinoin.
So you have used these combinations, you have used minoxidil. Minoxidil, is not responding.
Correct.
Then whether you go for, how often do you prescribe oral finasteride? And we all know, patient has, loads of, personal questions to ask whether it will lead to an erectile dysfunction, what will happen. There is a lot of, anxiety with this. So
yes.
How do you deal with that? And how often do you prescribe it? For how long do you prescribe it? And whether there is a patient adherence to it?
Correct. So Rahul, that's an interesting question. In fact, if there are like 10 people walking today on the promenade, if I ask 8 of them, everybody's heard of Minoxidil and finasteride.
Yeah.
Finasteride for the wrong reasons, unfortunately. See, we have to understand US FDA approvals are very difficult for a drug to get. If US FDA has approved a drug, a lot of research has gone into that drug, and that is definitely gold standard. Problem with finasteride now is there are a lot of blogs online. There is a post-finasteride syndrome page, which is run by a non-dermatologist and a non-urologist. Dermatology, urology, we are the highest prescribers of finasteride, but you will not find our presence or representation there. It's been given a bad name. But see, in the end, like I keep telling Rahul, we are not here to treat scientific papers or diagnosis. We have to treat patients. And patients ko jaise aapne finasteride likha, I call it the F word in alopecia. As soon as I've written the F drug, that is it. Patients are a doc, I'll do a procedure, but don't start me on this. I've had patients show 3 days ke medication, 3 days of oral finasteride, and they've come back telling me, doc, I had some issues with that, I don't want to take it. Then I have to tell them the drug takes at least 2 weeks to come into your blood circulation, you know, in something more than nanograms. But see, these are things which you have to tackle. So this is where topical finasteride plays a major role. If you look at the studies, topical finasteride also reduces serum DHT concentration by about 25%. By about 75%. And on the serum, it doesn't act as heavily. So I think that is one place where topical finasteride trumps. If I have a patient who's a little iffy about it, then I automatically shift them to topical finasteride.
So you are happy with the topical finasteride? It is a good addition to the armamentarium?
Definitely, definitely.
Welcome back, friends. We had a nice drive from the seaside and a short drive to the church, which is
the Basilica of Mount Mary.
Yeah, the Basilica of Mount Mary. So we discussed about Minoxidil, we discussed about the finasteride. Doc, young guy, follically challenged. How do you, losing his, girlfriends, I would say, how do you counsel such patients?
So I think, first of all, Rahul, I love the word follically challenged.
Yeah.
See, the thing with the hair is, most of my hair consults take 45 minutes to almost an hour as well, especially younger people, especially first consults, because I want to drive the point in that the treatment is going to be permanent. There's going to be a lot of, investment, not in terms of financially, but in terms of emotionally, physically. There's so many things which have to come together for a patient to regrow hair. So I'm almost always very, very cautious of this in the first go itself. I try to give them, like I said, 45 minutes of my time. I try to pacify them because, see, these are patients who need hand-holding. And if we're not able to talk to them, if we treat them like regular patients, then they will not come back to us. Or worst case, they will stop the treatment as well. So to ensure that they continue treatment, to ensure that they're on the right medications and they take them properly, I think counseling is of paramount importance. And like I said, my hair and vitiligo patients, these are two subsets. I take a lot of time, lot of hand holding. I give them my personal number. Any doubts in between, I'm there to clear them.
Great, great. What about the peptides which are there? As a monotherapy, do you use them, or as in combination, do you use them? We have spoken about combinations of minoxidil. How do you choose these hair peptides?
So, hair peptides are a very interesting market, like a growing market by the day. In fact, by the time we finish this interview, we'll probably have another peptide which would be released into the market. But jokes apart, peptides are there for a reason. We do use them very, very, I wouldn't say abundantly. I don't use it as much as minoxidil, but there's definitely a place for peptides. And, you'll remember the good old days when we had Wnt signaling pathway acting peptides. We had the CG peptides, which were a boon, and they were the first peptides that we...
CG knock-in and CG Karamin too.
Precisely. So they worked on the signaling pathway. So a lot of research now in the field of dermatology is happening on signaling, where you want the follicles to talk to the epidermis, you want the epidermis and the mesenchyme to come together as one unit. So that crosstalk is something which is of a lot of importance, and that is exactly where peptides hit. Plus, peptides are also good as protein. So they, give nutritional benefit to the hair. Hair is protein after all, it is keratin. So anything which, facilitates that will also be of good use. But yes, you name it, I use it. I use Redensil, I use Capixil, I use Procapil. I use the other ones, the CG peptide like we had discussed. And these are a few things which I would probably not want to use as monotherapy, but there are a subset of patients who don't want to use minoxidil. So in those patients, I think peptides are my go-to medications in certain effluviums. So I'm sure we're going to cover COVID effluvium later. Yes. COVID effluvium, when a patient is already shedding hair, that is the worst time to start minoxidil. So I'll probably start patients on a peptide then, and then switch them over to minoxidil once we have bought a little time.
All right. Dr. Aseem, when you go with the procedure modalities, there are PRPs, there are low laser lights, there is micro needling. These procedures are there. Is there a high reality in terms of clinical effectiveness? What do you comment? These are old procedures now. We have been seeing these. So, what is your take on that?
So, in fact, I've been doing PRP for 10 years now, and we've actually published guidelines on how to use PRP, and they are recommended globally. But coming back to the topic, I think procedural trichology, or as I call it, interventional trichology, this fills a need gap, because we discussed 40 to 50% patients will not respond to minoxidil because they don't have the enzyme which is required to sulfate it. They don't have enough of the sulfotransferase enzyme. Finasteride, dutasteride are challenged by crowd phobia. So, there's something that we have to take into. Peptides are not extremely effective, are not as effective as a minoxidil would be. So what are you left with? And there are patients who do not require a transplant but are not responding with medical management. So that is where interventional trichology has a big role to play. There are so many patients who we pulled back from a state where even I felt, in a couple of years we'll probably have to do a transplant, and those patients have hair, a plethora of hair now, and I'm very happy with the results. But to get back to it, platelet-rich plasma is something I use very regularly. At least 20 years of research in dermatology. If you look at dentistry and orthopedics, we have like 40 years of research. It's been here since the 80s. Low-level light and laser therapy for me is again an add-on. So, I have like an LED system in the office. You have to look for diodes rather than LEDs. That is the golden rule when it comes to LLLT. See, all interventional trichology, all procedures are add-ons to medicines. So if patients are not willing to take medical therapy, you don't prescribe interventional therapy. That is what my goal is from people.
So you feel that it is the right optimal strategy before a surgical intervention?
Exactly. So even in surgery, see, if a patient is bald, completely bald, then even this won't work. Even PRP won't work, your GFC won't work, LLLT won't work. These modalities might not work, microneedling. But if a patient is taking medical management and if a patient is able to regrow hair, these definitely work as a boost. So I think patient selection is the only key to interventional trichology. Very important.
All right. So it was minoxidil along with your oral finasteride, PRP and microneedling really works.
Oh, it does.
Yeah. So how about the nutraceuticals? Like coming to the nutraceuticals, which are those molecules do you prefer? And whether it is only a cherry on a cake or whether there is, you see, while combining it, you really find a difference.
So, nutraceuticals are a very important topic. Again, these are some things which, if you would ask me 10 years back, I would have given patients some B complex or some biotin-rich supplement and sent them away. Yeah. But nowadays, there is so much research, not only from India. See, as Indians, we are very agrarian, a lot of agriculture in our society. So, we do have a lot of crops which come in, but even here, our nutritive value of crops is going down. And not only Indian studies, but there are British studies published in, the British Agrarian Society, where they say that the nutritive value of crops is coming down. So what our parents used to have in terms of nutrition when they had, a bowl of dal and a sabji, or when they had something with, roti, they were actually getting good nutrition. But today we don't get the same nutrition from our food. Plus, we are all spoiled now for choice. We are all, into processed food, and we all eat at odd hours. All of these things make sure that we don't get adequate nutrition from our food. So nutrition is actually something which I'm telling you is already changing the game since the last 10 years. But in the field of hair, in the next 10 years, you'll see nutrition becoming of paramount importance. It won't be an add-on or a cherry like you mentioned. It will be on for every patient. So I think 90% of my patients are on supplements unless they have some contraindication and they don't want to take it. And since you asked me about nutraceuticals, I usually give combinations now. Plain biotin doesn't work. You always need to step it up with everything. You need a little bit of zinc, you need a little bit of manganese, you need potassium, you need sulfur-containing amino acids. So you need the whole gambit of antioxidants and nutrition together. What I commonly prescribe in my practice is cyclical nutrition. I'm very fond of that because that makes sure I'm getting the adequate dose of a particular supplement and not the adverse effects from it. But daily based supplements are also doing fantastically well. But most of my patients who come in for hair loss are on supplements.
Dr. Aseem, you are a hair expert. You have done a lot of research in trichology. Is there anything novel you can share? Is there any new procedure which you can share? Is there any new study which you really believe that, yeah, this would be a game changer, or, you know, this would really be, you know, there would be a day when there would be a drop of a solution and it would regenerate the hair follicles minus the hair transplant?
Okay, so that's a very interesting question. In fact, I'll take you back to the time I was in Barcelona for a European Hair Research Society conference, and the keynote lecture there was on hair cloning. If that is true, and the study is likely to finish by 2025, if hair cloning becomes a thing, if we are actually able to clone hair, then I think we will not be having such shoots anymore. We'll all go out of business very soon. But jokes apart, I think it would be a wonderful option for patients. You know, it will be a one-time thing. You clone hair and you're done with it. The only thing that is left to see is whether that works in actual practice. Before that, there are these cellular transport molecules called exosomes. They are also doing very well in the field of hair acne and anti-aging. They're very expensive as of now, not available in India, but they are very promising when it comes to hair. A lot of top researchers in the world are actually studying the role of exosomes in hair. If you move a little towards procedural dermatology, we now have growth factors which are umbilical cord derived. See, till now everything that we have is plant derived. So whether or not it works has always been debatable. You look at any conference, you put two dermatologists together and both will disagree on the use of peptides. One will say yes, one will say no. But if you have something which is human derived, human umbilical cord blood derived, I think that is the future. That's something which will definitely work. And people are also moving away from microneedling now to something like an erbium YAG, something like a fractional laser, which will not give you as much of a downtime. So it's more of a closed system where you can do it. But yes, I think put all these things together, and it's a very exciting time to be at least a researcher in the field of trichology. I mean, I'm loving the time I'm having right now in the field of hair because we have so many things coming in. We just need to pick and choose and see which ones work and which ones go off as hypes. So which ones remain as hopes and which ones go off as hypes. I think that is all.
So what I really feel is the quote "bald and handsome," you know, describing a male, you know, whether it would be wiped out, you know, one day, or it should be deleted out one day. You know, I would, you know, like to, you know, just open my cap and I would say that, you know, while I was in college and facing such a trouble, right? What have you done here 20 years down the line with, if I would have come to you?
So see, if you come to me right now, you're a perfect candidate for transplant. I think you've been told that.
Yeah.
You know that very well. But had you come 20 years back when you were just thinning, at that time, minoxidil supplements plus minus finasteride or dutasteride, I think we would have had something to go by now. And trust me on this. I'm saying this coming from a very, very big body of research and a lot of clinical evidence. We would have had something to live by right now.
Yeah, like you would have really made me marry the minoxidil and the finasteride.
Oh yes, you would be married to it by now. You would be carrying it for the shoot also. Trust me.
Right. So the COVID has gone. It has left the effluvium.
Yes.
What do you, you know, how about the female patients, and how about the ladies and the lovely ladies which, you know, get a lot of stress?
Correct.
In the daily life and the daily routine, right? How do you tackle such patients?
So like you said, COVID fortunately has gone now. I mean, now is very, very mild, but COVID effluvium is definitely something that we tackle with on a daily basis. In fact, so many of our seniors who were not seeing hair patients also ended up seeing hair patients. And if you remember, COVID effluvium, people would come with chunks of hair, you know, losing more than 200 to 250 to 300 hair in a day, which is very alarming for somebody, especially a woman. Like you rightly mentioned, the beautiful ladies coming in, they don't want to lose so much hair. And, you know, COVID also sparked off this trend where if somebody had patterned hair loss originally, it would activate it. So COVID worked in two ways. One was the hair shedding, the other was activation of patterned hair loss which a patient was genetically susceptible to. Now, how I tackle it is very simple. I told you, when a patient is already shedding, that is not the right time to give minoxidil. You buy time with peptides. In fact, Dr. Anil Abraham, I'm going to quote here, one of my revered seniors and somebody I learn a lot from. He and I had discussed during one of these web meetings where he said, when you're losing hair, it's a panic stage. So P for P, peptides for panic. And once the panic is over, M, maintain. So maintain with minoxidil. So peptides for panic and maintain with minoxidil. I think that works wonderfully. But COVID effluvium patients, because of the whole concept of autophagy, where the body is, losing too many supplements to other things, that is where you really need to step up on supplements. So nutritional supplements and peptides, those are my go-tos for COVID effluvium.
So all those patients, who are willing to go for a topical treatment, an oral treatment, but they are not willing to go for a transplant. How do you, convince those patients, and what really they want to understand about the hair transplant? There is FUT, there is FUE, there is robotic hair transplant. What do you do in your clinical practice? How do you, counsel such patients?
So I have a board where I have a plastic surgeon and another dermatologist who comes and does my transplants for me. We do follicular unit extraction as a rule. FUT, I think the scarring post-FUT, the linear scar, that is something that I don't want to give my patients. We run a very cosmetically intolerant practice, if I can call it. Patients don't want scarring, come what may. Baal nahi hai to theek hai. Scar diya to then that's the end of it. So FUE is my preferred method. We do FUE manually. I think robotic, in many conferences and in many international conferences, it's been shown beyond doubt that manual is the best method. It's still the fastest method and the most creative method. So while there are robotic centers in India, I think we are doing fairly well with manual FUE. And I think that's just to answer your question about transplants.
Dr. Aseem, cloning aayega and transplant aayega, that is all right.
Correct.
But still, the topicals, right? The topical solutions which are there, what are the new topical agents which you feel should be brought in, which could be approved in the near future?
So that's interesting. See, cloning jab aayega tab aayega, I agree with you. And as Indians, how much access will we have to it? I think that is something which, only time will tell. But tab tak ke liye, topical cetirizine is something which I found very exciting. I had heard a study about it at the American Academy of Dermatology this year. Then you have topical valproic acid. Imagine a leprosy drug repurposed as a topical. I mean, see, dekho, Minoxidil a few years back was the same thing, right?
Right.
Antihypertensive repurposed as something for hair loss. So, who knows what the future holds. So many new topical peptides which are, now being researched. Actually, like I told you at the beginning, the whole research is now focused on crosstalk. Wind pathway is like the pituitary gland of the hair. If something can stimulate the wind pathway, something can stimulate the noggin pathway, the sonic hedgehog pathway, we will have winners on our hands. But trust me, Rahul, when I say this, and trust me, viewers, very soon we will have a lot of new topical molecules which will be accessible to us. We only need to see how to use them and whether they work or not.
Thank you so much, Dr. Aseem. It was wonderful having you. It was a wonderful talk, and thank you so much for educating all our viewers on this. We would be meeting very soon. We would be saying goodbye to this hair series, and let us hope, sir, many more series coming in the future. Thank you so much, viewers, and thank you so much on behalf of DocShot, on behalf of Connect to Clinic. Thank you very much.
Thank you so much, Rahul, for having me, and once again, thank you so much, everybody who's still logged in. And I would love to hear questions. Drop your comments, your questions in the comment section. We'll be able to take them up one by one, and any other queries, we're always available. We have Connect to Clinic, we have DocShot, wonderful series being planned. I think, like I said, a very exciting time to be in the field of hair. Any of you suffering from hair loss as patients, any of you young dermatologists want to learn more about hair, I'm always available. You can hit me up, and we'll try to answer your queries as far as possible. Have a great day, ladies and gentlemen.
Have a great day. Thank you so much, sir.